select all that, apply. We know why we have hypocalcemia in severe pancreatitis. We done in our GI problems, that is on our YouTube. So sponification, if everyone is about does know about sponification, that's how we have low calcium. Okay, because in severe pancreatitis, we have too much lipase, and lipase release from inflamed pancreatitis break down the fat, and fatty acid then bind with the calcium in the body, and that will called sponification, and that's why you will have hypocalcemia. Okay, perio numbness and muscle spasm, we done that one. Yes, neuromuscular irritability, that's going on with hypocalcemia, and we will see A. Okay, you will see around the extremities, but if it is about hypocalcemia, you will find around the mouth also. What about B, guys? Hypotension and tetany risk. Is B correct? Yes. Okay, B is correct. B is actually correct, guys. We know. Okay, hypocalcemia, it causes vasodilation and hypotension. Okay, because it's too less. Hypo, yes. Okay, hypotension. And tetany, because we are having muscle spasm, and tetany is actually muscle spasm, involuntary muscle spasm, so that's why you will have B. Okay, and C is always as ordered, our golden rule, we never forget. And monitor IV sites, definitely. Especially here, they haven't said like whether it's calcium chloride or whether it's calcium gluconate, so it's depend. Okay, it will depend on what other electrolyte imbalance we are having together. What about D, restrict phosphate intake to treat hypocalcemia? What about D, guys? What about D? Yes. Okay, we are not gonna restrict, guys, remember that one, please. We are not gonna restrict the phosphate, because we know phosphate always bind with calcium. Yeah, that's why you will have hypocalcemia, I understand that, but that is not the correct way to treat hypocalcemia. If you will restrict the phosphate, you're gonna have hypophosphatemia also. Okay, unless body check the lab value, if somebody is in having hyper phosphate, then yeah, Jocelyn, you are correct, you are correct. Okay, but the thing is that we don't want to restrict it. Okay, we're gonna treat main component. Okay, if we are imbalancing the other component also, then problem gonna happen, we are gonna create another symptoms that will be related to the phosphate. Okay, yeah, because the primary cause is not the phosphate, primary cause is the sponification that happened to the pancreatitis. Yeah, Florical, you confused now, what's happened? Please tell me, I will let you know. We always treat the main trigger, we don't treat the other one. Okay, if you will keep treating the phosphate also, you will restrict the phosphate and to treat the hypocalcemia, but you don't worry about pancreatitis, then you're gonna have hypophosphatemia and hypocalcemia together. Calcium bind with phosphate, and that's why they are asking like if we need to restrict, because like we done tumor lysis syndrome, TLS, before, and in that one there is too much release of phosphate from the tumor cell into the bloodstream, and then you will see the hypocalcemia. Phosphate always bind with calcium. Okay, but in this case, this is not the reason phosphate is not the reason to cause hypocalcemia, so that's why we don't need to restrict that one. Reason is sponification, reason is too much lipase, reason is like those fatty acid binding to the calcium, not phosphate. Okay, so we will treat the pancreatitis, we will treat the lipase, we will treat those fatty acid, not the phosphate. Okay, if there are too much fatty acid into the body, they are competing with each other. Phosphate and fatty acid will compete with each other to bind with calcium. Okay, so that's gonna happen, so we don't need to worry about phosphate here. Thank you, Stephanie. Okay, observe for calcium soap in necrotic fat. This is the process, this is the actual process, this is the underlying cause that is happening, that is causing the hypocalcemia. Okay, this is the reason behind whole situation. So we need to worry about calcium soap, that is sponification. Okay, so the E is correct. Let's move to question number 22. A patient with acute tubular necrosis is oligouric. Which electrolyte disturbance and nursing priority apply? What about question number 22? So we know now AKI is, now kidney has injury, kidney can't excrete electrolyte and water. This can lead to the accumulation. So what's gonna happen, which kind of electrolyte is gonna retain? Okay, that's what we need to worry about. Hyperkalemia with peak T cell. Okay, failing kidney cannot excrete potassium. Yes, and that's why there will be too much accumulation of potassium in body and hyperkalemia will happen, and hyperkalemia will cause the peak T wave risk, okay, due to the arrhythmias. So that's correct. What about B, sodium retention leading to hypernatremia? Is it correct or incorrect? Is sodium gonna retain or we are gonna lose too much sodium? What is the kidney's function around sodium? Do we have sodium retention leading to hypernatremia? B is correct. Okay, guys, sodium retention definitely. Okay, ATN can cause sodium retention, but we just talk about this is oligouric phase. Okay, this is oligouric phase, there is not much water going out. What's gonna happen? You're gonna have hyponatremia, not hypernatremia. Okay, because now in ATN the body is not excreting sodium, body is also not excreting water and keep retaining the water. You will have delusional hyponatremia here. Okay, so B is incorrect. Yes, B is no. Thank you, Kaur. Monitor creatinine, BUN and daily weight closely. Is that correct? Is that R marker for the kidney injury? Yes, okay, because these are monitoring the creatinine especially, and renal function will help us to make sure like whether kidney injury is progressing or not. What about D, prepare for emergent dialysis if refractory hyperkalemia or overload? D, yes, D is definitely yes. Okay, because especially hyperkalemia, if can't, when it is refractory cannot be managed with medication, then we need to do the dialysis. Yes, I will explain triple after E. Encourage high potassium diet to correct hyperkalemia. E, no. Okay, we need to restrict high potassium diet, not refractory mean where medication are not working now. Where medications are not working now. Okay, because of what you said, lol. About what? Okay. Yeah. Okay. So option B, we know we have acute tubular necrosis. B- Kidney are not now functioning properly. Okay. And patient is in the oligouric phase. And when we have oligouric phase, kidney are not excreting enough water, urine. Okay. So now what happened? We are retaining sodium definitely along with the other electrolyte, but we are retaining the sodium and water together. Yes. Now we have retaining the water also. So oligouric phase, usually what will happen, sodium is retaining there and we will have too much water accumulation there. So this can lead to the hyponatremia, not hypernatremia. Yes. Okay. Osmolarity, I know body will try to compensate later on. Body will try to compensate later on, but it's not in, that's not the first effect. Okay. That will be the effect after this will happen. Okay. After the electrolyte disturbance, then body will try to make edema, like if, or maybe dehydration, like if it is hyponatremia, then person will start having the peripheral edema just to maintain that balance. Okay. But at starting you're gonna see hyponatremia first, because body is retaining too much water, body is sodium, we are not taking too much sodium inside from outside. Okay. But patient will be drinking water, patient are not unrestricted, and body will try to keep everything inside in ATN. So you will have too much water as compared to sodium, that's why it will have delusional hyponatremia first, and then you will have body trying to compensate, then it will be hypernatremia after the compensation, when patient will have peripheral edema. Okay. Yeah, water dilutes sodium and then the compensation will start, not before that. Firstly, it will be delusional hyponatremia. So that's why only is wrong. And we don't want to do this one because high potassium, otherwise all good. Okay, guys, 8 more question. I'm very tired right now. Question number 23. A patient on ACE inhibitor therapy, which electrolyte change and teaching point are appropriate? Select all that apply. So we know ACE inhibitor like lisinoprils, they block the conversion of angiotensin 1 to angiotensin 2. Yes. So we need to know they work on the aldosterone, and aldosterone normally promote the sodium reabsorption, potassium excretion, yeah, and keep the blood pressure maintained. But we need, okay, now what happened? Risk of hyperkalemia. Yes, A. Yes, definitely A. Because ACE inhibitor now gonna inhibit the conversion of angiotensin 1 to 2, and then there will be less aldosterone, then there will be less excretion of potassium. Okay, so then it will be hyperkalemia. We need to monitor that. What about B? Advise avoiding potassium supplement and salt substitute. B, yes, for same reason we need to avoid, because patient is already at risk of hyperkalemia. What about C? ACE inhibitor cause hypocalcemia routinely. Okay, this is the thing, this is the key word again. You don't need to know what they cause and how, but when it say routinely, this is always put question mark in my mind, like okay, this is something fishy. Okay, it's not typically associated with calcium level anyway, so routinely they are not gonna do that. What about D? Monitor renal function creatinine after initiation. What about D? Yes. Okay, because these are the medication metabolized. Yeah. So if especially somebody is having pre-existing renal disease, we need to monitor regularly because they can cause rise in the creatinine level. Okay, what about E, guys? Expect metabolic alkalosis as a side effect. E. No, yes. So they are not associated with metabolic alkalosis. Okay. In fact, like what will happen inhibiting the aldosterone can cause acidosis. Thank you, Pizza. Definitely, it will cause acidosis because there is not much excretion going on. There is not much hydrogen ion excretion going on through the urine. So that's why we will have acidosis. Let's move to question number 24. Okay, again, let's do that, guys, all together. ABG interpretation. We will definitely do how we learned before. Okay, I'm gonna make 3 lines. Okay, this is pH 7.35 to 7.45. What is our next normal level? What is PaCO2? What is PaCO2, guys? Thank you, Herman. 35 to 45? Yes, 35 to 45. And what is HCO3? 22 to 26. Okay, I'm gonna change the color. Let's do pH. Okay, pH is 7.33, so that is on this side. Yes. And then we have PaCO2 28, that is on this side also. And then you have metabolic component HCO3 on 22, it is 14. So we got everything on same side. So when it is on the same side according to the Rome, respiration opposite, metabolic equal, they are on same side. Okay, is metabolic acidosis. Yes, with the respiratory compensation, because what's happening now, respiratory compensation is also happening here. Is it correct or not? Because low PaCO2 is trying to compensate. Yes, everyone happy with that? Yes. Okay, so option A is correct. Primary metabolic acidosis with respiratory compensation. All three, this is partial compensation. Okay, this is partial compensation. If it is fully compensated, then pH need to be within the normal level. Yes, triple. Okay, because now all three are abnormal, that is partial compensation. Okay, yeah, all three out of range. If only two out of range, then it is uncompensated. Either it this and this, and if like suppose PaCO2 is normal like 36, then it is uncompensated. Now it is partially compensated with respiratory. Okay, so A is correct. What about B? Can be the cause diabetes, ketoacidosis, renal failure, lactic acidosis. B, yes, because this is the metabolic acidosis. Okay, this is metabolic acidosis. This is nothing related to respiratory. That's why you will say B is correct. Diabetic ketoacidosis producing too much ketones, renal failure, accumulation of uric acids and other acids, lactic acidosis also producing acids. Okay, yes. What about C? Anticipate low bicarbonate and possible hyperkalemia. What about C, guys? C, yes. Okay. Low bicarbonate is the component that is seeing it metabolic. Okay, that's why you can see it there. And possible hyperkalemia can happen. Okay, we learned about that because acidosis always cause the shift of potassium out of cell. Okay, Acidosis cause shift of potassium out of cell. If it is alkalosis, it will go other way around. Hypokalemia. Yes, pH down, potassium goes up. Thank you, JJ. Immediate treatment is IV sodium bicarbonate for all cases. So this is the keyword. Is it all cases? Yes. Okay. It change case to case. So we don't treat all cases same. So D is wrong. It's incorrect. Okay. What about E? Identify and treat underlying cause. Fluid insulin dialysis. Is E correct? Yes. So this is the most crucial intervention, especially like what patient is having. If patient is having DKA, then we need to give fluid and insulin. If patient is having renal failure, then we need to do dialysis. If patient is having lactic acidosis, we need to treat the underlying cause such as sepsis. Like what's going on. Please, do you have EKG? Yes, we do have triple. We can do someday. Okay, so this is done. Let's move to question number 25. A patient with COPD exacerbation. Okay, same thing again. I'm not gonna do that. You guys do. What it is? pH is 7.36. That is acidosis or that is normal? Let's do this. This is actually good one. This is gonna be compensation one. So 3 lines again. 7.35, 7.45. Okay, and then we have 35 to 45 PaCO2, and then we have 22 to 26 HCO3. So PaCO2, HCO3. Okay, I'm gonna change the color. So we have now pH 7.36. So it is standing here from the middle. Okay, 7.36. It is more acidic. Okay, it is toward the acidosis. Yes, so it will be compensated. Okay, now we need to know what's here. We are having PaCO2 60. Okay, that is more on this level. Okay, and we are having HCO3 34. So what's happening here? This is acidosis, respiratory acidosis, because according to the room, respiration need to be opposite. Okay, and our first step is checking the pH. Second step is checking the PaCO2. Okay, is it partial or is it fully? It's not bestie. It is because now pH is falling under the normal, so it is fully compensated. Okay, many if it is only partial if all 3 are wrong. Okay, all 3 are out of range. If pH is 7.36, yes, it is fully compensated. Okay, fully compensated respiratory acidosis. So metabolic compensation, because metabolic is also falling toward opposite side. Okay, so this is the another thing. When we say metabolic, they need to, because now we have more acid and now it is toward acidic side. This need to be toward more basic side. Many in fully compensated, you need pH normal. Now pH is normal, so that's why it's fully compensation. If pH is 7.34, then it's partial compensation. Okay, if only pH is wrong and respiration is wrong and HCO3 is normal, like 23 maybe, then it's uncompensated. Okay, so A is correct. Definitely A is correct. It is chronic respiratory acidosis with metabolic compensation. B, acute worsening with elevated PaCO2 may produce, B, patient may have chronically elevated bicarbonate. Is it correct? Make sure you guys remember B. Yes, B is yes. Okay, because kidney are compensating for chronic CO2. Okay, and that's why they can have retaining bicarbonate over there. So definitely B is correct. What about C? Acute worsening with elevated PaCO2 may produce somnolence. C, yes. Actually, C is yes. Okay. Why? We this is we have studied today hypercapnic encephalopathy. Okay, now body is retaining too much carbon dioxide, that is gonna cause hypercapnic encephalopathy, and that will produce the necrotic effect on the brain, that will make confused drowsiness and loss of consciousness also. Okay, what is D? Immediate IV bicarbonate is indicated. D, no, giving bicarbonate immediately is gonna be dangerous. Okay, so we don't wanna do that, because patient is already, body is already compensating, body is already correcting itself. Okay, so we just need to wait and watch and correct the underlying cause. Okay, don't worry about ABG right now. Correct underlying cause. Okay, thank you, NP mentor. So this is not gonna do that. What about E? Avoid aggressive oxygen therapy without monitoring. E, yes, correct. Okay, why we need aggressive oxygen therapy? Because there is a chronic retention of carbon dioxide. Okay, and when we have high dose oxygen, it can, I know it can suppress their respiratory drive, because it's not gonna be more longer driven by the carbon dioxide, that is usual normal, but by low oxygen level, it can happen. Yeah, so we need to avoid it. Okay, we're gonna give low oxygen level, hypoxic drive, not the, like we don't want to suppress their respiratory. So avoid oxygen therapy without monitoring O2. Yes. In COPD, the range is 89 to 92. Yes, that's correct. Because like in chronic CO2 retention like COPD, oxygen not gonna helpful be at all. Patient not gonna will start retaining CO2 more, like, yes, okay. But by low oxygen level, they do. More oxygen, more retaining. That's gonna happen. Okay. Let's move to question number 26. We are gonna do 30 question today. That will be the end of session. A patient received multiple unit of PRCB rapidly after trauma. Which electrolyte acid base disturbance should the nurse monitor? So we know multiple unit, that is the massive transfusion. Okay, packed red blood cell, and they can cause lot of imbalance, but which one we need to be very worried about? Anyone? A, yes, hyperkalemia from stored RBC. Okay, that is the worst one that we can see. Okay, guys, they have higher potassium concentration, especially the packed RBCs. So hyperkalemia, definitely. What about B? Hypocalcemia due to the citrate binding CO2. Yes, B is yes, definitely. Okay, what happened there? Because there is citrate in the blood product that can bind to the ionized calcium into the person's blood. So that will be like calcium is there, but now it's not more available. So that can cause the hypocalcemia. What about metabolic alkalosis from citrate metabolism? What about C, guys? Nope. Actually, yes. Okay. So C, yes, also, because citrate is normally used as a anticoagulant. Okay, and it will be metabolized by liver into the bicarbonate. Okay, citrate is bicarbonate, and when it is metabolized, it can cause metabolic alkalosis. So okay, so you can have that one. What about D? Risk of lactic acidosis and hyperphosphatemia. Can we have that one? But how? D, yes. Simone, definitely D, yes. Why we will have lactic acidosis here after major trauma? Why we can have? We don't have enough blood in body. Okay, all the organs, muscles, and tissue is yes many. Okay, having hypoperfusion, they will go more to anaerobic oxygen deficiency and they will do the lactic acidosis. And when we have that one breakdown of blood product, they will also do like muscle damage. Yeah, they will release the phosphate also. Okay, and when we have more phosphate from the bloods and from the muscles, then it is will cause hyperphosphatemia. Yes, it is for NCLEX. Yes. Okay, no special monitoring required. Do we need monitoring or not? Yes, okay. We need patient especially on the cardiac monitoring because there is higher risk of life-threatening complications here. Okay, we do need. Thank you guys. Yes, definitely because we post video on YouTube also. So all this live will gonna go on YouTube. So please subscribe Nursingi on YouTube too. So a patient with hyperparathyroidism has calcium 3.1. Which finding and intervention should the nurse anticipate? Hyper. So we know parathyroid gland produce parathyroid hormone PTH that can increase the serum calcium level. Okay, so in hyperparathyroidism there will be too much PTH and that can lead to too much calcium. Okay, so polyuria and dehydration risk, is it affected? Is A correct? Yes, A is correct, especially because calcemia, what will do? They will impair the kidney function to concentrate the urine. Okay, so then body will start excreting too much urine, and then patient will have dehydration. Muscle weakness and decrease reflex. What about B, guys? What about B? Yes. Okay. High calcium act as a sedative. We know high magnesium also work as a sedative and calcium also work as a sedative. Okay. Especially on the neuromuscular system, it will cause lethargy, weakness, fatigue, and hypoactive reflexes. What about C? Administer IV fluid to promote calciuresis. About C, C no. Actually, it is correct. Okay, because we have hypercalcemia and we are having already polyuria. Okay, so we need to do that. Okay, and it will help us to correct it. Okay, body is already losing too much fluid and yes, and we need to do that. We need fluid. Okay, otherwise calciuresis definitely will happen. Yeah, encourage high calcium diet immediately. Oh my god, we don't want to do that. We already having calcemia. What about monitor ECG for shortened QT interval? What about that? Yes, okay, because hypercalcemia can shorten the QT interval. Yeah. Yes to E. 3 more questions, guys. Make sure you subscribe YouTube, please. Really appreciate. Okay, let's move to question 28. Okay, a patient on amorphotizin B therapy, which electrolyte abnormality and nursing action are important? Thank you for the gifts, guys. Really appreciate, bestie. we are having, what kind of medication we have there? Amphotericin, what kind of medication we have? Anyone? We done pharma last week, guys. I know it's a long antibiotics. It is actually antifungal medication. Okay, it have lot of side effect and especially severe renal toxicity. This is well known for renal toxicity. Okay, yeah, it will straight cause damage to the renal tubule and everything will start leaking. Hypokalemia Hypermagnesemia risk. So now we know. So we have renal. It is antifungal. It is antifungal. Okay, now we know it causes severe toxicity to renal tubules. So now renal tubules are damaged. Are we gonna see hypokalemia hypomagnesemia risk? No, why no? We will see that. Okay, because now body will start losing all the electrolytes in the, yeah, no, it's not gonna reverse. Okay, just for A, its body is gonna lose all the electrolytes. There is nothing reabsorbed or retaining. Usually kidney doesn't let excrete potassium, okay, and reabsorb sodium. Renal toxicity, monitor creatinine urine output. Is that correct? B, yes, because we know there is now injury to the renal tubule, and definitely we're gonna see the increased creatinine level and urine output. What's gonna happen with urine output? You will see number of things over there. You will see nitrogen waste over there, everything. Yes, decrease, definitely. Preemptive potassium magnesium replacement as ordered. Yes, Nico, definitely. This is very potent medication for antifungal, especially if somebody is having from long time. Okay. What about C? Okay, this is the golden rule. You don't know answer. If it is as ordered, make sure you tick that as correct. Okay, even you don't know. Honestly, 99% time it's correct. And because we know in this scenario, yeah, we know in this scenario we are risk of hypokalemia hypermagnesemia, so that's why we need to do the replacement. What about expect hyperkalemia as common side effect? What about D? No. Everyone happy with no? Yes. We are not gonna see hyperkalemia, okay, because we are gonna see hypokalemia. Slow infusion rate and check IV site. Slow infusion rate and check IV site. What is drug classification for above? Just confused about K. What is confusing many? Definitely this is correct. What is confusing about that? Can you please let me know? We can talk. We can discuss. Why it's hypo and not hyper, please? Because one of the function of kidney is to balance the electrolyte, okay, and kidney doesn't let potassium excrete in urine when is functioning normally. And now what happened, we have, because this medication is very potent, yeah, same on the kidney is damaged, it not excrete. No, it will excrete, guys, it will excrete. Yeah, usually, yeah, kidney usually filter stuff, okay. Now there is no filtration going on, kidney doesn't know what's going outside. No. Okay, what is normal function of kidney? Okay, let's do that. Okay, normal function of kidney. How normally it work? So main function is filtering. Yes. Yeah. Reabsorbing. You are tired. I am very tired. Yeah. Filtration. Okay. Yeah, it is not reabsorbing electrolyte correctly. Okay, so it is everything that is crossing that renal tubule is excreting. Everything. Okay, so that's why. Okay, let's do CKD, hyperkalemia, hypermagnesemia, hyperphosphatemia. Yeah, in chronic you can have it's depend like what stages of CKD they are on. Yeah. Yeah. Because now we don't have the renal tubule, there is too much toxicity going on. Everything is not filtering, everything is not reabsorbing, everything is just voiding in the urine. Okay, let's do 29. Let's do two more questions and then we can talk about all our concerns. A post-op patient with excessive NG suctioning, which electrolyte ABG manifestation might be present? So we have NG suctioning, so that means we are getting most of the acid out. Yes. And then what's happening? Metabolic alkalosis with elevated SCO3 is correct? Yes. Yes. Okay, because there is too much loss of hydrogen and chloride ion from the stomach. What about B? Hypochloremia, hypokalemia. B, yes. Yeah. Okay, B is yes. We done previous question also. When we lose stomach acid through vomiting also, we lose potassium. Okay, and chloride, HCl. That is our stomach acid, hydrochloride. Okay, decrease respiratory rate at compensation. C, is C correct? Is body trying to compensate now? C is yes. Okay, because compensate for the alkalosis by hypoventilating, slow down, and trying to retain the carbon dioxide, which will increase the acidity. What about hyperkalemia from volume loss? Shouldn't be metabolic. No, it is metabolic alkalosis, many already metabolic alkalosis, but respiration compensation. Okay, it is not saying respiratory. Yeah, we are now gonna see hyperkalemia. Provide chloride replacement. What about E? E, yes. Okay, we need to provide chloride, especially normal saline will be good. Okay, because if we are replacing the chloride, it will help the kidney to excrete excess bicarbonate also. Okay, HCl, yes. Okay, let's move to last question about today, hi Mangs, and then we are done for today. We done 30 question, guys. This is the longest session, not longest, we have done 6 hours one day. A dialysis patient skipped treatment and is short of breath with potassium 7.0 mmol per liter. Which nursing actions are priority? Lovely Mags is all gonna be on YouTube. If you are on YouTube, you didn't miss anything. Promise. By tomorrow, all these 30 question is there. Yeah. Uh, okay. Put patient on continuous cardiac monitoring. What about A? Yes. Yes, definitely we need to put cardiac monitoring. What about B? Administer IV calcium gluconate per order. What about B? Yeah, it does not help to lower the potassium, but it will stabilize the cardiac membrane. Thank you, Nico. Yes. Okay. What about C? Give IV insulin with glucose to shift potassium. C, yes. We done C, yes, into the cell. Okay. C, we're gonna see. Look, IV, when we are giving the insulin, it's gonna work on sodium potassium pump and to stabilize the potassium. Okay, but it also gonna cause the hypoglycemia. So that's why you need to give glucose. Okay, insulin function is to reduce the glucose. So make sure we are not causing hypoglycemia just giving the insulin. Okay, give oral sodium polycistrate sulfonate for rapid correction. Can we do D? No. Okay, this medicine we done in our pharma session. It's not about rapid. Is sodium polycistrate doesn't let potassium reabsorb in GI tract. Okay, what it will go, it is the exchange resin. Okay, it will remove the potassium, and this is action very slow, so it's not the first line treatment. Okay, it's not gonna help with that. It's not gonna do anything what is already inside the body. Okay, yeah, it's excreted in feces. It's not gonna help that fast. Prepare emergent hemodialysis if refractory. We already done this question before. If refractory means medications are not working, uh, other measures are not working, so we need to do the hemodialysis to correct the potassium level. Okay, so just to A, refractory always means you have tried everything else, nothing worked. Oh guys, thank you. We done 30 question today. That's a lot. We are gonna come back tomorrow again, same time, 10 p.m. EST. So we were done another 30 question. We will do how we correct potassium fast rapid correction. We don't, you don't correct the potassium fast.